Good evening, everyone. The IISc team welcomes you to yet another amazing session of our VT Talks. Today, we are honored to have Dr. Abhishek Mangeshikar, founder and director of the Indian Center for Endometriosis, to deliver a talk on endometriosis, an overview and mythbusting. Thank you for joining us here today.
Thank you, Shlok, for the introduction and, of course, for having me here. Endometriosis is a very important subject to me. This is the only disease I treat. I'm a gynecologist based out of Bombay. I don't treat any other disease. I only treat endometriosis, and that's what I specialize in. So I'm going to talk at length about this subject, and I want this to be as interactive as possible. So I hope everybody has a lot of questions, and I'm happy to discuss them. So there's no such thing as a silly question. You can ask me whatever you want. It's a safe space, and I look forward to interacting with everybody who's tuned in. All right. If we're ready to go, should I start my presentation first?
Sure.
All right. Right. Can you see my slide deck?
It's not yet visible, sir.
Oh, it's not yet visible. All right, let me try again. Let me know now. No, it's not visible yet.
It's visible, sir.
Ah, okay, fantastic. All right. Okay, so good evening, everyone. And I'm going to talk to you this evening about endometriosis. It's the most common disease you probably haven't heard of, or if you have, there's a lot of intricacies and fallacies even within the medical community that need to be addressed. So I'm going to attempt to do that today. So it's the most common gynecological condition, and it is among the top 5 most painful conditions any individual can experience. So I'm going to start with this little pictograph series, which was from an artist called Lily, and she has published it on her website as well. So it all begins with a young lady who begins adolescence, and she gets her first period at the age of 12. And a lot of these adolescents experience such severe cramps that they're unable to attend school. And this is a very fragile point in their lives because their friends seem to have much easier periods. So they start to wonder if there's something wrong with them or if they're weak and the parent and the familial structures are also a little bit at fault here because they're gaslit and they're told that this is normal, it's part of becoming a woman. And once they get older and married and have babies, that everything will be fine. Now, it became apparent very quickly that the periods weren't normal, and the inability to attend school or social activities may lead to introverted behavior or even depression. So if you look at the top right of the screen, there's a photo with this young lady who has burns on the abdominal wall. And this is a very common picture which you see with endometriosis patients because they use such chronic use of hot water bags that it creates superficial burns on the skin. And then as the disease worsened, the symptoms progressively worsened as well. Nausea, blacking out from the pain, headaches, fatigue, bloating or the endobelly. So sometimes they look like they're almost 5 months pregnant, but this is just from the entrapment of gas within the intestines that can cause severe bloating as such. So they tend to first visit their doctor early on in their teens. And the problem is general gynecologists are very adverse to treating the disease. So doctors tend to undertreat or not treat adolescent endometriosis. And they get gaslit with the same story. It's part of becoming a woman, get married, have a couple of kids, and you will be fine. Okay, so this is the problem that starts early on. We should be able to identify this earlier, but it's getting progressive. So as she gets older, the periods become more painful and other seemingly unrelated symptoms arise, which become, food sensitivities, allergies. She gets misdiagnosed as IBS and a whole other load of symptoms, nausea, vomiting. And this, as a good clinician, doctors should realize that this progression of symptoms should give us an idea on the evolution of the disease and what organs are possibly getting affected. So she tried to get answers from many doctors and online, but hit so many dead ends. The internet is a great place, but it's also a terrible place for information because you're overwhelmed with information and a lot of it can be incorrect. So unfortunately, this has become the norm, where the average patient with endometriosis sees 9 to 10 doctors and has a 7 to 10 year delay in getting a diagnosis because they're told something bad, periods happen. Let's put you on a hormonal pill to stop the period. Let's induce menopause chemically, IBS, IUD, anxiety, and other things. So now we need to know what is endometriosis. It's when there's tissue similar to the lining of the uterus called the endometrium. It's not the same thing as the lining of the uterus. It is just similar to. That lines the inside of the uterus that grows outside the body. Outside the uterus, which is most commonly in the pelvis, but it can also grow in the abdomen. It can grow in the chest. It can grow in the lungs. It can grow in the muscle. There are even reports where it has grown in the eye or in the ear or in the gums of the teeth or in the nail bed. So it is much more severe than a bad period. It is beyond the gamut of routine gynecology because it affects multi-organs systems. The pain is very severe, and it's much, much more severe than just regular menstrual cramps. If you look at the symptoms here, there's fatigue, brain fog, migraine, chest pain, nausea, food sensitivities, sciatica, if there's involvement of the nerves, that's the big nerve in the lower back that shoots down the leg, painful bowel movements, painful urination, painful sex, and leg pain. So by the time she was 25, she had already been on 7 different types of birth control, developed 7 new food allergies, skipped more days of school and work, and been to the emergency room a bunch of times. So it's not a disease that kills immediately, it's a disease that kills quality of life, which is probably worse. And you see, if you look at the statistics, it really impairs academic growth, career growth, and the ability to be socially functional. Then, of course, she found a social media group, which was a good endometriosis patient support group, and lots of patients, will Google their symptoms, which is not a bad thing in this day and age. You should encourage it, but also learn to direct, as clinical practitioners, we should direct our patients to the right resources and have that discussion with them rather than saying, don't Google your symptoms. Of course, this is one of the groups that she was on. I think this is the largest group for endometriosis support. And for the first time since the age of 12, she understood what her diagnosis was. And the statistic of 1 in 10, which is now 1 in 9, because we are diagnosing it better and more people with the disease are speaking out. And we are still, till this day and age, it still takes 7.5 years on an average to get a diagnosis from the onset of symptoms. So that really needs to change. And of course, the only treatment that works as of right now is excision surgery, which is done through minimally invasive surgery, which is when a gynecologist uses laparoscopic tools to cut out the disease from the roots, not just burn the disease at the tip, because that's called ablation or coagulation or fulguration. And we're going to talk about that in a minute. So she finally got directed to an excision specialist and was able to get the treatment that gave her a quality of life. Now, so that's a great way to introduce this disease, I thought, and I'm thankful that she had put out that work. So what is endometriosis is defined as the presence of tissue that resembles the lining of the uterus occurring outside the uterus. Can occur anywhere in the body, all right? We've no cases very commonly within the ovaries, the bladder, the bowel, the kidney, the ureter, which is the tube that joins the kidney to the bladder, the appendix, the small intestine, the skin, the diaphragm, which is the organ that separates the chest from the abdomen, liver, heart, brain, name it, you can find endometriosis there. Now, everyone is always wondering about the causes, and the most common one, but probably the most incorrect, which doesn't answer all our questions, is retrograde menstruation, which is when the belief that the period blood flows backwards. Now, that is not the answer, because the endometriosis and the endometrium are different entities. So when they looked under the microscope and studied them a little closer in detail, they found out that there were vast differences between the two. The only similarity they have is the presence of endometrial cells and stroma within the endometriosis disease. So there are other theories postulated, like the genetic epigenetic theory, mulariosis, which means that these disease tissue is laid down along certain paths and tracks as an embryo develops. And there are 15 other theories. So the short answer is we don't really know what the cause is, but it is not, since there are different types of endometriosis, it's not really easily answered by one mechanism of action. Now, we know the types of endometriosis can be ovarian, which are the chocolate cysts, which probably most people will have heard of. But the more severe kinds are peritoneal and deep endometriosis. So superficial and deep, those were arbitrary measurements used. They don't really follow that pattern anymore. So we prefer to use peritoneal endometriosis and deep endometriosis. So deep endometriosis are big nodules that can grow in the bowel. They can grow anywhere in the body, whereas thinner lesions or usually affect only the peritoneum. Now, the peritoneum is a structure like a film that lines the entire abdomen and pelvis. So it covers the bowel, it covers the pouch of Douglas, covers the uterus, covers the ovaries, covers the side walls as well. Now, this is a laparoscopic view of a normal pelvis. If you see the uterus up here, these are the uterosacral ligaments. This is which join the uterus to the tailbone. And this pouch of Douglas, under that is where the rectum passes. These are the ovaries on the left and the right side. So everything is clear and free here. But endometriosis literally looks like somebody threw a hand grenade into the pelvis and it blew up and everything got stuck together. So you see the ovaries are stuck to each other here. The rectum is stuck. There's no pouch of Douglas visible. And that's how bad the disease can get. So much more than a painful period. So like we said, it can be abdominal pain, which can be related to the period or not related to the period. It can be chronic pain, where they have pain for 30 days out of the month. It can be pain during intercourse, which is usually when there is a nodule at the back of the vagina or the rectum is stuck to the back of the vagina. This can also, by distortion of the anatomy and by the inflammatory processes, interfere with fertility. So we have infertility or subfertility. Chronic fatigue, bloating are one of the most common symptoms. Pain during ovulation, pain with bowel movements, constipation, diarrhea, or both can occur when there's infiltration in the bowel. Pain while passing urine, pain in the pelvic region, lower back, and or the legs. Having trouble when on holding when the bladder is full. Frequent urination, heavy bleeding, irregular periods, many, many more symptoms. If it's sciatic nerve, it can be radiating from the buttocks down the hamstrings. If it's on the lower back, that usually means uterosacral involvement, which is what we saw near the pouch of Douglas. And if it's under the rib cage or on the scapular area, you're suspicious for diaphragm endometriosis. So this was a good BBC study in 2019, which looked at something like 20,000 patients with endometriosis. And out of those 20,000, 84% on survey reported a decrease in the quality of their work. 20% reported being temporarily disabled. 40% reported stunted career or academic growth. 3% reported total incapacitation. 1% attempted suicide at some point, although 50%, that's 50%, had suicide thoughts at some point in their lives because of the pain. So this is a very serious disease that needs to be given its due diligence. So we see that the average patient has seen 7 to 10 doctors, and we know that the diagnosis is delayed. before they respond to a specialist. Now, the pitfalls for the endometriosis patient come from the failure of support from the peer group and the family. They also faced with gaslighting from the medical and the familial backgrounds. So that means the family support tells them get married, have children, your pain will go away. The medical fraternity does the same thing. They're told to have. And the sad reality is that women in pain are not taken as seriously as men in pain. If a man presents to the emergency room with testicular pain, every test under the sun is offered to rule out severe conditions, whereas it may not necessarily be offered to women and or minority groups. So, of course, endometriosis diagnosis is very important. We need to be able to improve our diagnostics. The first step in making the diagnosis is to listen to the patient. Okay, why I practice only endometriosis and I don't practice other obstetrics or gynecology is because we need to give our patients time. A consult with a patient takes approximately 1.5 to 2 hours because one needs to listen to them, where their pain is, how the pain presents, what makes it better, what makes it worse, what is the radiation. That is going to give me a mental map of how the disease is presenting, what are the types of pain and their location, a detailed history. These patients have spent many, many years seeing many doctors, so we need time to review everything. If you're seeing 50 patients who are in a pregnancy or a general gynecology OPD, there's no way you can give the endometriosis patient enough time to have a detailed diagnosis. And of course, the examination should be done as gently as possible and the required imaging. So when it comes to treatment, we need to understand that the best treatment as of right now, what we have available is surgical excision of the disease by an expert, which means cutting out the disease from its roots. Now, medical treatment is not treatment, it's medical management, because medical treatment, there's not a single medical drug, hormonal or non-hormonal, that is available on the market today that can treat the disease. There's not a single research paper that shows any medicine causes a regression of lesions. The only medication that is given, hormonal or non-hormonal, is to control the symptoms by either suppressing estrogen or by giving pain medication. All right. So we have medical therapies such as painkillers, which are non-steroid anti-inflammatories, the opioids. We have birth control. We have injectables, which act on the brain to suppress the ovaries. And we have alternative therapies, but those have not been peer-reviewed, very well researched and randomized trials, so we don't know how effective they are. Now, surgery is not easy. Like I said, it's even more difficult than cancer surgery, whereas cancer in gynecology has its own subspecialty. Endometriosis is yet to develop as a subspecialty, although it desperately needs to. Surgical removal of the disease dramatically improves quality of life as long as it's done correctly. This is an interesting paper from De La Hera Lazaro, which showed that the mean visual analog score for pain was 8.5 out of 10 before surgery. And after surgery, it reduced to 1.4 out of 10 on an average. And this was in 2016. So when we talk about surgery, this is burning, which is ablation, which should not be practiced. This is excision, which is where we scoop out the disease from the roots. So when you burn it, you don't know how deep the disease is. If you think about it like the iceberg, where only 10% of the disease is above the surface and the 90% is under the water. And if you only treat the disease on top, you're leaving the main disease, which is entrapping the nerves and the vital structures, still in place. So the patient is going to have no relief. When they looked at data studying the differences between ablation and excision, ablation had a recurrence rate and non-resolution of symptoms in the ratio in the range of 50 to 80%, whereas excision, the rates of deep endometriosis recurrence dropped to less than 10%. So I apologize in advance. There are some surgical pictures, and this should be the last of it. But this, if we look at it, is a laparoscopic view. And to a normal gynecologist, this is how far, if you look at this top left image, this is how far they will normally look at the pelvis and say, okay, maybe there's some endometriosis up here. Because these are the typical lesions that are described in literature. We see the powder black or chocolate brown lesions. So that's an endometriosis lesion accordingly. But that is not just the only lesion. When you look closer, you have to do a near contact laparoscopy. So bring the telescope very close to the tissue, and then you look a lot closer and you see different types of lesions. So we see, apart from this lesion, which is the hemorrhagic powder bone lesions, we see new blood vessels forming. So that's also early endometriosis. We see white fibrotic scar tissue over here. So that's also endometriosis. And you see clear vesicular pattern lesions here. So this is all endometriosis. So a regular GYN who is not trained to identify endometriosis will only go and burn this singular area and ignore all of this disease, whereas an endometriosis specialist who treats this disease will go and cut out the whole area here, so that we just remove all of that peritoneum, and this is how the disease needs to be treated. So, of course, when we look at the literature, as I mentioned earlier, when you look at a broad look at literature where every Tom, Dick, and Harry published their research on endometriosis, whether they were doing ablation or excision, showed recurrence rates ranging between 6 to 67%. But when you narrowed that microscope and looked only at the endometriosis specialists or the endometriosis centers, the recurrence rates dropped to less than 3% for deep endometriosis and less than 10% for ovarian endometriosis. And this is a huge difference between what is reported in a broader literature and when you look at specialist centers. So obviously they are doing something much different. They're diagnosing it better and they're doing better surgery. So of course, my personal series follows similar to what the specialist centers do, as is only natural for a team that practices only endometriosis. So I like to use this to demonstrate how there is no consensus in endometriosis care in the field of gynecology. So if you look at something like a simple analogy, like a patient walking into the office of various doctors seeking advice on a painful splinter in the finger, the first doctor says, take these pills, they should sort out the pain. The second doctor says, I can't see the splinter, there's no splinter, it's all in your head. The third one says, I'm just going to burn the top of the splinter off and that'll take care of the rest of the problem. The fourth one says, I think we should cut off the entire finger and probably the hand. And the fifth one says we need to remove the splinter in its entirety, including the root that is embedded in the flesh. So I would hope that all medical practitioners would strive to be like Dr. Number 5 and remove the disease in its totality, while also being respectful of the rest of the patient's functions. So this is a very interesting slide from a friend of mine who said there are different camps in the endometriosis community. The first one is the should not operate camp, because these people who are incapable of doing correct surgery, so they believe surgery is never the answer, give the patient medication and hope for the best, which is a good thing to practice if you don't know how to do the surgery, because at least you're not harming the patient. And then eventually you can refer the patient on to a specialist. But I say that very tongue-in-cheek. This is a horrible way to treat patients, because they should not be wasting time on unnecessary medical therapies if the lesions require treatment in the first place. The second is the incomplete excision camp, which would believe if you remove some, the rest will go. But this is akin to saying you don't know if you're giving the tiger a haircut or if you're cutting off the tiger's head. So you better be able to remove all of the disease, because if you go and try and shave a tiger, you're going to end up in a lot of trouble. The ablation camp says there's no evidence for which is better, so we'll do what's easier. Then you have the treat it like cancer camp, who do very radical surgeries on all patients and try and do hysterectomies and removing the ovaries as well. But this is not the treatment for the disease. By definition, which exists outside the uterus, it is unjustified, unwarranted, and should be re-examined as a therapy to remove the uterus for a disease that exists outside the uterus. And like I said, we should all strive to be complete with our excision to remove the disease, but also take respect and care of the patient's ovarian reserve, reproductive function, nerve function, bowel and bladder function as well. Okay, now who should do surgery? Should it be the gynecologist? And within the gynecological community, should be the laparoscopy surgeons, the fertility surgeons, or gyne-oncologists? The answer is, or should it go to urology or general surgery? The answer is that even with experienced laparoscopic gynecologists who were not trained in endometriosis, the recurrence rates were huge, almost 40%. So the answer is, will you ever go to a general surgeon to have surgery for a brain tumor? Now, for a disease that is much more complex than cancer, there is a need for the endometriosis surgeon, which should be a high volume center dealing only with endometriosis with a multidisciplinary unit in place. And that I mean gynecologist led with an expert in ultrasound, expert in diagnosis, expert urologist to treat urological or bladder dysfunction, colorectal, so for bowel disease, and thoracic surgeons, as also other allied specialties like physiotherapists, pain specialists, reproductive specialists, sex therapists, and counselors. And we need to all have to be working together as a team, trained in endometriosis excision, and tailor the radicality of the surgery to the patient's needs. Now, to reach the end of my talk, I want to address a lot of FAQs that patients ask me. So I thought I'd share those with you all. So many patients think that just because they have a diagnosis of endometriosis, they need a hysterectomy. So it is not a treatment for endometriosis at all, unless there is a concomitant uterine pathology like a uterine cancer or fibroids or adenomyosis. And even when hysterectomy was performed, there were huge retreatment rates for patients because the endometriosis was outside, probably in the rectum or the appendix or in the upper parts of the intestine, that was untreated. So these patients required another surgery after that because it was not diagnosed well enough. Now, like I said, we need to really re-examine this as a modality because most guidelines across the world, that is the American College of Obstetrics and Gynaecology, the Indian Society for Gynaecology, and the UK societies define definitive treatment for endometriosis as removal of the uterus and the ovaries. This is absolutely incorrect and really must be re-examined. The second is patients with an early diagnosis of endometriosis think that they all require IVF. The reality is only maybe 20 to 30% of patients with endometriosis have fertility issues. And I want to explain this by the slide. So we have a typical scenario in our practice where a 30-year-old with a diagnosis of deep endometriosis in the rectum will walk in to the clinic, and of course the doctor will say, what is your priority? Would you like to treat the pain first or get pregnant first? Now, the patient being altruistic and everything will say, okay, I would like to get pregnant first, and then maybe I'll deal with the pain later. So the doctor says, okay, we're just going to put you into an IVF procedure and we will have multiple IVF protocols and then we'll see what happens. Now, the problem is this question in itself is wrong because it suggests that the two goals of treatment cannot be attempted together. Now, there is enough evidence to show that removing the disease not only improves pain, but it also improves pregnancy rates. And I mean natural pregnancy as well as those requiring ART procedures. So if we look at this interesting paper, and there are many, many, many other papers similar in this vein coming out, which shows that excision surgery allows conception rates of around 80% within the first year of surgery. Those are very good statistics. And out of those 80%, almost 60% conceive naturally. So this not only improves natural pregnancy outcome, but it also dramatically improves IVF outcomes. So this surgery first should be the norm for those seeking fertility, as well as for those seeking treatment for pain. Now, when it comes to why medical therapy fails, is like I said earlier, because medical therapy is aiming at managing the symptoms. It is not aimed at treating the disease. Unfortunately, what medications we have today are used to suppress the endometrium to stop periods from happening. Now, they suppress estrogen, or the female hormones, related flare-ups, which is a transient absence of symptoms, but no regression of the disease. And endometriosis is hormone dependent and not only estrogen dependent. And furthermore, it also secretes its own estrogen through the cholesterol pathway. And when the disease can continue to grow, although it may be asymptomatic, it can progress in spite of a patient being on medical therapy. Then this is the most common one. Does pregnancy cure endometriosis? Now, I thought that this myth was already relegated to the past, but unfortunately, it still propagates today. And I'm sure many people listening will have similar experiences that many doctors have told them to get pregnant and the endometriosis will go away. Now, the reality is that pregnancy, like hormonal or drug therapies, is going to stop menstruation and may temporarily suppress the symptoms of the disease, but by no means will it eradicate the disease. Furthermore, pregnancies in the presence of endometriosis have a higher incidence of pregnancy loss and miscarriage, have a higher incidence of early labor and preterm and premature labor, and also some slightly higher incidence of birth defects. So it is very important that we understand that pregnancy is not a cure or prevention of the disease, and symptoms, if present before, will recur as soon as the child is delivered and breastfeeding is completed. So we need to understand that why the medical community has completely dropped the ball on endometriosis is because we were taught the wrong definitions and causes in medical school, and therefore the practices that permeated after that share light in a similar vein. We know that there is a huge delay in diagnosis from the onset of symptoms. And among OBGYs, there's such a strong hand of pharmaceutical companies that, again, the guidelines for endometriosis will say that suppression with medical therapy is the first line of treatment. When it's not treatment, it is only management of symptoms. When we know that surgery is the way to remove the disease. And secondly, I will tell you a personal experience because I'm an expert on the subject. I was invited by one of the Indian gynecological communities to formulate guidelines. And as we reached the meeting, it was sponsored by a pharmaceutical company, and we were only allowed to form guidelines based on the research papers that the pharmaceutical company handed out. Now, of course, these were cherry-picked and probably funded by the said pharma company. So needless to say, I obviously walked out of that meeting. But if you see the strong, pervasive hand of pharmaceutical companies, it is the patients are put on very long-term suppression medications without actually treating the disease. So this is something that really needs to change in our profession. And there is no training curriculum in laparoscopy in the residency level, although it's quite rudimentary at best, let alone for something as complex as endometriosis surgery. So there has to be the onus on someone to have an interest in this disease to go and train themselves after their residency. So a resident or a graduate in gynecology is ill-equipped to handle this disease completely. And women are just told to get pregnant. So what can we do? So we have to understand that pain is not normal. Pain that is causing debilitation and an alteration in the quality of life is not normal. And again, primary treatment with NSAIDs is wrong. Patients with no response should be referred to specialist centers. It should be very important to understand the history. We should have awareness programs within the community, partnerships between patient associations and endometriosis centers to make sure that fewer patients slip through the cracks. And primary care physicians should be able to diagnose and direct patients towards appropriate centers. Now, I started the Indian Center for Endometriosis more than 5 years ago now, as the India's first and largest referral center for endometriosis. And we've been treating patients successfully from all across the country and across the world. This is the website. This is the social aspect of it to create awareness, but obviously the center is a multidisciplinary team, which comprises all the members I spoke to you about. And this is what needs to be done. So we have to create awareness within the community. We have to educate not just patients, but also medical professionals about what needs to be done for this disease, how to improve the diagnosis. Even radiologists and sonologists are not able to diagnose beyond the chocolate cyst. They miss a lot of endometriosis in the rectum or on the nerves, so which only the specialist centers tend to diagnose. And we also need to empower individuals assigned with this disease or diagnosed with this disease. It is not only a women's disease, it affects transgender men, it affects non-binary individuals assigned female at birth, and there are also 19 cases in literature where it has affected cis males. So we also need to build a healthcare network to identify professionals who can treat this condition and work with researchers to find solutions and better causes. I also work personally with the Indian Council for Medical Research, and we have studied the tissues and different types of endometriosis to see if there are patterns that we can identify. And of course, we need much, much more research into endometriosis, because surgery is only at the end of the day. If we look at the spectrum of the disease and what We estimate about 190 million worldwide, and there are only about 200 endometriosis specialists in the world. They're not even going to begin to scratch the surface when it comes to how many patients require treatment. So of course, surgery is the answer only right now, but we would have to obviously find better ways to treat this disease. I thank you for your time, and these are my socials. If you're interested in learning about endometriosis, or if you have any queries you need to reach me with, you can screenshot this, and I'll be happy to respond to you on any of them. Thank you.
Thank you, sir. That was a great presentation. I would especially like to appreciate illustrations, which made everything quite easy to understand. Our design team has taken notes, and we'll try to incorporate something similar in our awareness campaigns. We can now take some questions from the. We can now take some questions from the audience. Aman asks, can you please detail out the evidence that led you to dismiss retrograde endometriosis as a cause? Retrograde menstruation as a cause of endometriosis?
Yeah. So there are a couple of things that will say that retrograde menstruation is not the only cause, or probably not the cause of endometriosis. So if you look at the work of Dr. David Redwine, he has fantastic presentations on that. And the simplest thing I can tell you is that there are patients with Mullerian anomalies, right? And a Mullerian anomaly means that there are patients who are maybe born without a uterus, or maybe, missing some of their organs. So those patients still have endometriosis. Then there is an Italian study which studied fetuses of 700 fetuses, and they found evidence of endometriosis within those fetuses. Okay, now you can't tell me that fetuses are menstruating, because that's not possible. Thirdly, if retrograde menstruation was the only cause of endometriosis, the treatment would be to go and cut off the tube, because that would stop retrograde menstruation and no patient would ever have endometriosis then. And cutting off the tube is the simplest procedure in any surgery known to man. It is literally what is called tubal ligation, what is done as a sterilization procedure. It takes almost 2 minutes to do. Endometriosis surgery to do properly takes a couple of hours. And we also have extra pelvic locations of endometriosis where you can have it in the lungs without having any endometriosis in the pelvis or the abdomen. So how does retrograde menstruation account for that? Or we've had cases where it grew in the ear, or in the shoulder, or in the bed of the fingernail. So how does endometriosis reach there? Retrograde menstruation is not the answer for all of these presentations, and definitely, if once we stop getting stuck in that mindset that it is the only cause of endometriosis, then we're going to move forward a lot faster in the hopes of finding a solution.
The next question is from Swaraj. Given the lack of knowledge regarding endometriosis, can you recommend some books, articles in the present day academic literature to know more about the disease?
Okay, so like I said, there are very good resources online. The good place to be would to start with those support groups. Like I mentioned, Nancy's Nook is the biggest one. They have a tremendous library of resources that is available to the public. So you would start there. And if you have access to PubMed, I think a good amount of peer-reviewed articles from the good centers. Unfortunately, that's very difficult to pick out, but you will see trends of authors putting out regular publications, like some of the ones I cited, like Horace Roman, who is a mentor and a very close friend of mine, and one of the reasons why I am practicing endometriosis today. His work is exceptional, and I think he has probably the largest series in the world. So, when you have a wealth of experience like that, it's very good. Those people have a lot of experience to talk about the disease and what the outcomes are and what the correct way to manage is. So those are the website things to look into. Books are not such a great idea because books don't go through as rigorous a peer review process as research papers. So, if you look at medical literature, most people in gynecology who write books are the ones who are what we call outstanding surgeons, because they're not they never stand inside the operation theater. They're just outside and pontificating and not doing anything actually for the patients.
The next question is from Sheesh. He asks, can you tell us something of the ongoing research on medicines and if there is actually any scope of improvement there because surgery might involve some degree of risk?
Right. So the problem with medical thing is that pharmaceutical companies are just kind of rebranding old drugs in a new avatar. They keep using GnRH agonists or birth control or just progesterone to suppress the lining of the uterus. The goal that most pharmaceutical agents have as of right now is to stop menstruation. So it's kind of stalled. I think there are some other researches going on into alternative medications, but we have no good data out on it yet, or no signs over the horizon that anything promising is coming up. And of course, surgery is risky. Surgery has its own risks, but not treating the disease is far riskier than doing surgery, in my opinion. There is a very real entity called silent kidney loss, where patients have been put on medical therapy and they miss the disease which was trapping the ureter, and this causes the patient's kidneys to fail, and they eventually required to have their kidney removed. But so I think ignorance and under training and uneducated or lack of education about this is far riskier than expert surgery.
Aman has one more question. He asked, during our investigations, which we were doing for our project and in our project, we understood that earlier diagnosis might lead to more effective treatments. Do you agree? And if yes, do you think research should aim for earlier diagnosis or better treatments?
Absolutely. I think it works hand in hand. So diagnosis is the key. So let's talk about diagnosis in two ways. The first step is to listen to the patient, give the patient enough time and listen to their symptoms. So that itself should give you the inkling that something is wrong. If you listen to a patient's story, it presents itself in a way that kind of leads the map out for you. Secondly, imaging in the hands of an expert versus in the hands of somebody who is not trained in endometriosis are very different entities. Now, let me explain it to you. When a patient goes in for an ultrasonography and they have a transvaginal ultrasound, the standard ultrasound report only looks at the uterus and the ovaries. Okay. Now, if the disease is in the rectum, they're going to miss it. If the disease is in the pelvic sidewall, they're going to miss it. They don't look for fixity of the ovaries. So now, unless this patient only has an ovarian cyst, like an endometrioma, then she will have a diagnosis of endometriosis. But other diseases will get missed. So we're missing out a whole bunch of disease because we're not picking up cysts in the general ultrasound setting. Okay. The second problem is most gynecologists don't do their own ultrasounds, or they don't read their own MRIs. They rely on the radiologist reports. Now, in my practice, I do my own ultrasound, and I also read the MRIs myself. Also, I work with very good radiologists who are experts at reading endometrial ultrasounds, but I understand that though that is not available to everyone across the country who practices medicine. Now, it is very important that to replicate this, we're working to try to teach AI how to map out the disease. So we're taking out human factors from there. So to standardize the readings of these imaging. And that being said, imaging is good. Even in expert hands, it's not going to diagnose everything. So negative imaging doesn't rule out the disease. Negative imaging rules out ovarian disease and deep disease. So that means if you have a normal MRI report and the patient has pain, and you have no deep endometriosis picked up on the MRI or the ultrasound, and you have no ovarian endometriosis, and she has pain, you should still go ahead and do the laparoscopy to rule out peritoneal endometriosis, because you cannot see that on imaging.
Thank you again, sir, for this enriching session. We would also like to thank everyone for joining us here today. We'll be back with another insightful sessions.
Sure. Thank you. I hope I answered all the questions well enough, and this was an interesting session, and I look forward to further interactions with you all.
Sure. Thank you.
All right. Thank you.